mainly because I'm a surgeon, not an intensivist, and I wasn't sure what the audience would be. It's probably a little straightforward for you all, but I'll go through it anyway. But this is clearly the first talk we're having, and we can have other talks and we can discuss them at other levels. And because the intensivists are here, they'll be able to tell me where I'm wrong. So today we'll talk about things like, what's the time? You've got till 3?
Yeah.
Oh, we'll move along. CSF circulation and physiology, normal and abnormal intracranial pressure, external ventricular drainage, brain herniation due to increased intracranial pressure, and the identification of neurological deterioration at the bedside. So, just to revise the anatomy of the CSF pathways, there are the two lateral ventricles, so that's ventricles 1 and 2, the left and the right. They don't actually have a number, but you do have a third ventricle. So the two lateral ventricles drain into the midline third ventricle, and that little thing there, a round thing, is the interthalamic adhesion, which is present in only a small proportion of patients. The third ventricle then communicates via the cerebral aqueduct of Sylvius to the fourth ventricle, and the fourth ventricle has 3 openings. It's got the midline foramen of Magendie, and that's easy to remember because midline M, and the 2 lateral foramini Luschka, so Magendie in the midline and Luschka at lateral. This is the foramen of Monroe, where each of the lateral ventricles join into the third ventricle. So you've got 2 lateral ventricles joining through the foramen of Monroe to the third ventricle, the third ventricle by the cerebral aqueduct of Sylvius to the fourth ventricle, which has 3 outlets. So the CSF is manufactured inside the lateral ventricles. It passes down through the third, then down through the cerebral aqueduct. Now, you've heard the saying that the naval convoy is as fast as its slowest ship. So in a way, there are points of vulnerability in the cerebral anatomy, and this is a point of vulnerability because clearly it's very narrow and it doesn't take very much external pressure to block it off. So just bear that in mind. The fourth ventricle, the outlets from the fourth ventricle, and the CSF then disperses both down the spinal, over the spinal cord, and up over the cerebral hemispheres, and it's reabsorbed in the arachnoid villi, and it returns into the sagittal sinus, and it's reabsorbed into the circulation. So the CSF is produced by the choroplexus at a rate of 20 mils per hour. The total volume at any one time is 150 mils. So 20 mils production by 24 hours, so we're getting about 500 mils per day manufactured. So you've got to process that 500 mils. That was butt dial. Okay, so if someone's having a lumbar puncture performed and we test the fluid pressure, what can you recall what it might be approximately? Well, it's in the normal situation. You don't do lumbar punctures on normal people, but it's in a normal person who's relaxed or anaesthetised, the pressure is going to be around about 10 to 20 centimetres of water. So I, as a neurosurgeon, we used to talk in centimetres of water because that's how we measure it, and that's what we do with EVDs. However, when you're measuring intracranial pressure, using your electronic apparatus which is connected to the EVD, it's actually millimetres of mercury, so 7 to 15 millimetres of mercury with an upper range of 20 to 25. But in centimetres of water, it's 9.5 to 20 with an upper range of 27 to 33. And I don't know if you remember these conversion factors to go from mercury to water. Now, I think it's important here that if you're looking after a person using an EVD to measure intracranial pressure, you're monitoring in centimetres of water, but then if you look at the monitor, it's in millimetres of mercury. So it can be potentially confusing if you're talking to somebody saying this is the intracranial pressure. It's a point of confusion. So raised intracranial pressure can be caused by a lot of issues. Hydrocephalus, which is one of the things we see more frequently in intensive care, but of course there's trauma, which is a major contributor. Brain tumours, I don't know whether you see a lot of those here. Big cerebral infarcts, occasionally there can be a big cerebral infarct where there's a large temporal lobe which even sometimes needs to be decompressed, or a bleed inside a temporal lobe which needs to be decompressed, and of course infections such as herpes encephalitis with very, very swollen temporal lobes. So there's many causes of raised intracranial pressure. Now, has anyone heard of the Monro-Kelly doctrine, the Monro-Kelly hypothesis? You probably all have. So, excuse me, Michael Redmond.